cancer journey doesn't always stop once treatment is complete. For one woman, survivorship has been the hardest part, both physically and emotionally, but she still calls cancer a blessing. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Pam Wilson got the bone marrow transplant that she desperately needed. Then her immune system turned on her, fighting against the donation meant to save her life.
Come on, buddy. You want to go look at the flowers? There's times if I'm out here working in my garden, I literally have to lay on my back in the grass and just focus on my breathing because the pain will grip me so bad.
Pam Wilson's pain is the result of a stunning diagnosis she received back in 2019, putting her into the fight of her life.
My back of my skull started hurting so bad that I felt like someone was put my head in a vice grip and was just turning it. And I thought, I'm going to have an aneurysm. I'm going to blow.
She was rushed to her community hospital where they ran blood work.
And the next thing I knew, they came in my room. They said, we believe you have leukemia.
Acute myeloid leukemia, a rare but aggressive blood cancer. Pam would require a higher level of care and an immediate bone marrow transplant for any chance at survival.
So yeah, it went from me thinking I had strep throat to I was almost dead.
She was transferred to the University of Kansas Cancer Center, where her treatment and a search for a donor began. Time was running out. Then the news came. Her sister was a match.
I'm now my sister. My DNA doesn't exist anymore. It's her DNA.
But the transplant was half the battle. Pam developed what's called graft versus host disease. It's when the donated stem cells think the recipient's body is a threat and starts to attack, causing everything from skin rash and inflammation to nausea and severe fatigue. Pam had it all.
And that's when I became so depressed I didn't even want to live for a while.
But through the Cancer Center's Graft versus Host Disease Clinic, Pam is able to manage her symptoms with steroid injections and medications. She even sees a therapist here who helps her through those mentally tough days.
This is where I like to sit and I draw flowers. I try to sketch things.
And she lives each day to defy statistics. Hers, a 25% chance of living past 5 years. Pam's on year 4.
Before I felt like it was a ticking time bomb, and I still feel like it's a ticking time bomb because you never know when it's going to come back. But every day is good. He's my baby. He's a good boy.
She takes nothing for granted, like the 2 grandchildren she never thought she'd live to meet. And she's a full-time writer now, something she never thought she'd get the chance to do.
I actually feel like cancer was a blessing. And that's weird to say, but it is. It's true. So pretty. You're so pretty.
And we are so glad to welcome Pam Wilson to our program today, along with her oncopsychologist, Dr. Elizabeth Muenks, right here next to me. And across the table, we have Dr. Sunil Abhyankar. He's a hematologist and medical oncologist here at the Cancer Center, as well as the director of the Midwest Stem Cell Therapy Center. And Pam is with us, of course, so welcome all 3 of you. Nice to sit here together.
Nice to yes, good morning.
Yes. Isn't it great?
It's awesome.
It's always good to reunite. Pam, you were told that without this transplant, you would likely be dead by September. I mean, they were blunt about it. You were blunt when you told me about it. It was just like the stark reality. You got your transplant in August. How bad was it leading up to the transplant? I mean, you were on borrowed time.
Yes, it was rough since I was diagnosed on June the 5th, and from June 5th to August 30th, when the transplant was performed, I was undergoing treatment. So, and the treatment is to knock the blast out of my system. So I was very weak and deconditioned walking into the transplant.
So, Dr. Abhyankar, tell us a little bit about AML, and is a stem cell transplant, is that a cure for it? So tell us a little bit about both and what you were looking at when you met Pam.
Sure. Good morning, and thanks for having me here.
Of course.
So acute myeloid leukemia is a rare cancer, but it is a deadly one. And the majority of folks who have acute myeloid leukemia have high risk of the leukemia coming back with just general chemotherapy. And that's when we need to look for donors and do a donor transplant, which can cure the cancer. So when we do the donor transplant, we're replacing a patient's immune system with the donor's immune system. And the leukemia has successfully evaded the patient's own immune system. And so by replacing the immunity, we build up the immunity against the cancer coming back.
So when you first met Pam, tell us what that was like and what you were looking at with her.
So with her type of leukemia, we had to look for donors, and the first thing we do is look at the family members who are available, and she was lucky to have a sister who was a match. There's a 25% chance in the family that you may have a match within the family. So that made it a little bit easy, you know, because we had a donor at hand. And then before the transplant, Pam had to receive chemotherapy to clear out her whatever residual leukemia cells they might still be hiding, and also to suppress the immune system so you don't reject your donor's stem cells.
So we talk on this program a lot, and we've mentioned, we've talked about stem cell transplants and AML, but this particular program is about graft versus host disease, something that I wasn't familiar with and have learned quite a bit about since I spoke with all of you. And so tell people exactly what it is before we talk about how common it is.
You know, as you rightly mentioned earlier, graft versus host disease occurs when the donor's immune system wants to fight the recipient or the patient's body. And because that's what the donor cells, immune cells are designed to do. They are designed to attack something that looks foreign to them. And even though the donor and the recipient are well matched, there are still very, multiple differences in the DNA that the immune system recognizes.
So is it common enough to where you tell patients this is something that could happen? How common or rare is it?
Absolutely. How frequently it occurs depends upon who the donor is. So the incidence is higher if it's a donor who is not related to the person and from the donor registry. And it's less when we have a matched sibling donor like you did with your sister. But the incidence varies anywhere from 30% to 60%.
So does having graft versus host disease mean that the transplant failed or wasn't as good as a match? What does that really mean?
No, it does not mean that it has failed. It just means it's a complication that we have to we know of, and we got to look for it and treat it. As soon as we determine that's what's going on. There is a little, background in this. When people used to get transplant from the identical twin, let's say somebody with leukemia has an identical twin sibling, and we'd use their stem cells to do the transplant. It's a perfect match, 100% match. There is no graft versus host disease there, but there is a high risk of the leukemia relapsing because the identical twin has the same immune system as the recipient.
Yeah, that makes sense. So
there is a little bit of benefit of having some degree of graft versus host disease. When you have a little bit of graft versus host disease, it also fights against the leukemia.
Okay, so there's a benefit. Thank you for explaining that really well.
Sure.
That really made me understand it. And we learned so much about the journey of cancer. Some people are just waiting to get over the finish line of treatment. In your case, Pam, you said survivorship has been really the biggest struggle for you. Tell us about that and why.
Sure. For me, the actual treatment, the chemotherapy, all the stuff that was happening to me, I had the best team of doctors between St. Luke's Hospital and then when I was transferred to KU. I didn't really focus on the treatment. I focused on just doing what they told me. Really bearing down whatever they said, I did, even if it was difficult. And they did, even prior to the transplant. They had a class for me and my family talking about graft versus host disease, but in the back of my mind I said, I'm an athlete, I'm fit. I'm not even going to think about survivorship and that. I'll ace that.
Right.
And so I really didn't focus on that until it hit me. So that has been my hardest part, is the psychological, the ongoing graft versus host disease, how it continues to creep in.
So there's the physical aspect of it.
Yes.
So that's why we have Dr. Muenks here, is to talk about the mental aspect of it. How did graft versus host affect you in your recovery mentally?
It surprised me paramount, and then I realized it was causing anxiety. I didn't know what anxiety was. I never had an anxiety disorder before. Really didn't have depression. But Dr. Muenks helped me realize that's what you're experiencing. This is a process, and she was wonderful. She guided me through it. She got me to the right clinics. I go to a survivorship clinic and a palliative clinic with her guidance. So
you're super tough cookie. Were you a little apprehensive about going through all this? You said you could kind of lick this. You've got this part. This is going to be the easy part, and now you're being told you have to kind of, go through this, down this path you weren't expecting.
Exactly. That was a shock to me. I mean, I fought it for a while. I thought, I must not be doing something right, because this is for me, it was the hardest part, was dealing with the emotional, and my life changed drastically. I no longer had the career I had for 30 plus years, had to reinvent myself, and it was scary. I was afraid, and I had anxiety, and I needed Dr. Muenks.
And it's hard to need someone. So Dr. Muenks, tell us a little bit about what it was like when you first met Pam, and just, was she a typical case of somebody who wasn't really expecting to be sitting there face to face with you?
Yeah, I think that's a big part of what we do, is normalizing that it's such an adjustment after you've worked so hard to go through a stem cell transplant, and you go through induction chemotherapy, and then you go through the transplant. You've got 100 days of 24/7 caregiving. You're in the hospital. You do this marathon to beat your cancer. And then in survivorship, you deal with something like chronic graft versus host disease, which almost feels like a setback. It feels very psychologically like, I crossed the finish line, I've beat my cancer, and now I have this other major thing to deal with. And a lot of inherent losses along the way. Like I think you mentioned, people are not working the same way. People like Pam, who are really tough cookies, really physically active, that's an outlet for them. They can't do the things they used to do, and that really psychologically sets in and makes people worry about what their future is going to look like. It can really put them in a funk, in a hole of like, my life is never going to be the same. What did I even do all of this for?
So what kind of tools are you presenting to patients like Pam?
I mean, patients like Pam already have a lot of tools.
Yeah, okay, so she was your easy patient.
So,
kind of.
Our patients are they're experts on themselves, and so I always try to remind them of that. But also, there are great approaches to treating things like depression and anxiety, and a lot of that has to do with changing how you think, changing what you do to have an impact on how you feel. There's also a reality of the situation that sometimes you can't sugarcoat it. It just kind of is what it is, and it's more about acceptance and figuring out how you can obtain a quality of life that makes it feel worth being here for.
So it's like mind, body, and soul, Dr. Abiyankar. You're there to kind of fix it and help with the physical state. How important, though, is it to make sure that Pam is connecting to someone in our onco-psychology program like Dr. Muenks?
It's extremely important. We are so lucky to have Dr. Muenks and a team here at KU. They say it takes a village, to kind of really recover from all the things that we do in transplant. And without the support and help from the survivorship clinic, and then Dr. Muenks and a team, going through this would be extremely difficult. Yeah.
So, Pam's talked a little bit about her treatment, and getting through the physical treatment then helps. It's kind of a trickle-down effect, helps with the mental standpoint. So, are there other additional treatment methods that she could use to get through graft versus host? Tell us how you're managing that a little bit more in depth.
Yeah. So there are a lot of therapies that we have. The first important thing is to catch it early and detect it. So that's where we need the dermatology colleagues' help. If there's a skin rash, we need a biopsy, and sometimes the biopsy is not indicated what's going on. Then we have to kind of discuss what the plan is and treat it like a GVHD. Because graft versus host disease it's like a morphia. It can present in different ways. And one interesting fact, and Pam, I don't know if you mentioned this, but Pam had myasthenia gravis before her diagnosis of leukemia.
And what is that?
That is is it okay, right?
Yeah, absolutely.
Sorry, I asked you. But it's a condition where our own immune system develops antibodies to the neuromuscular junction. So in effect, what happens is that our muscles contraction decrease, muscles become weak, like eyelids droop or difficulty in swallowing, because those muscles become weaker. So then you got to take medicines to fix that. So it's again an immune attack against the neuromuscular disease. And with the transplant, so one of the other benefits of transplant is that that myasthenia gravis is gone. Yeah. So previously, because we have a new immune system now.
I love what you said, though. I don't think people realize that. Like, there's the good, the bad, and you trade off one thing for another. It's a trade-off.
It was a trade-off.
It's a trade-off.
That's right.
And when I walked in this morning, if I could say, you were like showing me the rash that you had developed on your leg. You said, actually, this is doing better, but you said you had to go back on steroids. Is that right?
Yes.
And that's part of this.
It is part of the process.
It is part of the process. Are all patients, cancer patients, offered oncopsychology to help them through this time?
I mean, we're really lucky at KU Cancer Center that there's a oncopsychology team. So we are available to all patients and families and caregivers. BMT is unique in that we meet just about every patient before an allo transplant to do kind of a pre-transplant evaluation and meet patients and sort of say, like, hey, how you doing? What can we do to keep you kind of strong through the process? And here's some things to be on the lookout for. But we don't sometimes see patients until much later. Sometimes we see patients while they're admitted in the hospital. So we're fortunate at the KU Cancer Center that our patients within BMT and outside all of our oncopsychology team members meet the needs of the cancer center as a whole. But that's not every cancer
everywhere.
center.
So it's about educating our patients and letting them know that it's available, and we're here for them in that way.
Right.
Pam, you were 30 years occupational therapist.
Correct.
You had to say goodbye to your career and kind of reinvent yourself, as you said. But did having that medical background, did that help you have just a better understanding of just kind of how did that affect how you got through this?
Yes, I was fortunate. I was in the health profession for 30 years, and although I treated many cancer patients, I was a lymphedema specialist. I didn't know anything about blood cancers.
Interesting.
So I did had to educate myself, listen to the doctors, and I think my medical background made me understand what the doctors were saying and take it very seriously.
But you're on the flip side of things.
Yes.
Always very interesting to be sitting on the other side of the table.
Oh, it's different.
It is. Dr. Abiyankar, it's Monday. I know you have a busy schedule. We're so glad you came with us. We're going to let you scooch out of here. But before we go, I just want to see, Pam, is there anything you want to share with Dr. Abiyankar before I let him go?
Certainly. I just want to thank you so much. I'm blessed. I truly am blessed that I ended up at KU, Major Cancer Center. I get you, the best. I get Dr. Muenks, the best. I'm in good hands, and I am so grateful that you remain committed to KU, because all of us here in the area, we've got a great doctor.
Yeah.
You made me emotional.
We love making you cry. You know, that's always my goal, to make you cry. Abiyankar, it's like, this is what we hear when people see you, when your patients come back. Pam, I have to say, this is kind of what everybody says about him. Dr. A, he's the best.
He is.
And
he truly is.
So
Time for me to leave, I think.
Now that we've totally warmed you up, just any quick takeaways you want us to walk away with today before we let you go?
So as we hear from Pam's story, doing a transplant is a journey, and often people think, oh, I'll get the transplant, then I'll be fine afterwards, and that's not how it is.
Right.
It's a long process, but at the end, there's a light at the end of the tunnel that you can cure somebody with leukemia.
Thanks for all the work you do. Let you get out of here. And I know
Thank you.
we're going
So
to see
good
each
to
other
see
in a
you.
bit.
Yes.
So thank you and have a great
All right.
week. Be sure to ask your questions for Pam or Dr. Muenks, because they're sticking around with us. You can use the chat on YouTube or Facebook, or you can use the Medical News Network. All that info is right there on your screen. As you know, since the start of this pandemic, this program has brought you the COVID count. We do it every single day. The goal was to be transparent about how many COVID patients that the health system is treating on a day-to-day basis. But starting this week, the health system is stopping its internal COVID tracking dashboard that we have used to share these numbers for over the last 3 years. And that means that we're changing how we deliver the numbers. So let's bring in Doc Hawk. He can kind of better explain how this is going to roll out. Good morning.
Yeah, hi.
Hi.
I mean, I'm glad we've gotten to this point. You know, that means that for the most part, the pandemic is over. And again, there are different definitions of what it means to be over. Some people say that when it no longer affects your daily life. Certainly we know for a vast majority of the population of the United States, that has been true for some time. But we also do have to remember there are those patients and those populations of patients out there who remain at high risk. And so we really want to do everything we can to continue to educate and give that information to help protect those patients and their families, the preventive measures, the treatment measures as well. So we will definitely keep giving some numbers, but we are only going to be reporting active cases, no total cases, and really no ICU breakdown of cases as we have in the past as well. So for today's count, we have a total of 5 active COVID cases in the health system in the hospital here.
All right.
Yeah. And as you can see now, we've had it put up there, we have actually this active graph, which is really nice, and it just shows where we were in the past year. And you can see those numbers, those lines, the large blue line of cases, and how much it has dipped and has decreased to where we're sitting today. So I think overall, compared to last summer, we're doing very well. And you can see that for yourself there. We know we do have questions usually about, you know, how does this compare to before? Why are you not presenting as many, or why do we think the numbers are lower, and do you think they will be higher? Obviously, if the numbers do start to be higher, we can always pivot and try to present those numbers as we used to when those numbers become significant. And we know that in the last couple of weeks there have been that talk or that concern that maybe there is a shift towards increasing hospitalizations. We haven't fully seen that in the last couple of weeks, but the only thing that we can do is continue to track those numbers, and then we will present it to you if the situation arises.
Well, I think I speak for all of our viewers. They appreciate you being here day after day after day.
Yeah.
Other than letting you get out of here for a little vacation in R&R every now and then, you have been here every single day doing this, so we appreciate you very much.
Thank you.
Any reporters with us today? All right, let's get to some community questions. So how long has onco-psychology existed?
Yeah, so the official name of the field is psycho-oncology.
Psycho-oncology. We have it backwards. So I've been saying it backwards.
We did it backwards.
I do that a lot, okay?
No. Our program is called Onco-Psychology.
Okay, good. Okay, but
so
we wanted to stand out. Okay,
yes,
gotcha.
we just wanted to be different because I think it's a little bit more inviting for patients. Psycho-oncology just has kind of we found that patients sort of responded to that terminology, kind of like psycho, what does that mean? Am I psycho?
I see it.
But our official field is psycho-oncology. Jimmy Holland is a psychiatrist out of Memorial Sloan Kettering who started the field in like the late 70s. And as a psychiatrist, her and 2 colleagues started meeting these like psychosocial needs. They noticed that, you know, cancer patients really struggled with depression, anxiety, adjusting, you know, working with their families, with navigating, you know, just all the stress that comes with dealing with a cancer diagnosis and its treatments and its ramifications. And then from there went on to train psychologists to do this work. So the field, I would say, is kind of relatively new, but again, we're really lucky that we have a team of specialists doing this work at KU.
Has there ever been any research or even any research on the horizon about like the impact physically on taking care of your mental health and treating this as part of the overall plan?
Absolutely. I think there's great research to show improvement in survival when you're treating the person as a whole and treating their emotional and psychological needs. A lot of patients, we try to correct a misconception that like their stress caused their cancer, or like if I'm not all positive all the time, it's not going to be okay. Kind of this like toxic positivity approach, which just isn't the reality of the situation. And there's no research that shows that you have to have a positive attitude and that's the only way you get through cancer or you survive.
Okay, good to know. Yes.
So
it just can help.
It just
anything
helps.
helps.
Yes,
right,
absolutely.
Right. Randy wants to know, do you also see families and spouses and partners, and how does that work and how does that help?
We do. You know, patients come with their families and caregivers. Often they bring people to their appointments, so we kind of do, you know, what's needed in the moment. Our caregivers, oftentimes in bone marrow transplant, specifically in that group, we see that the distress is actually higher in caregivers than the patients because they have such a huge responsibility of taking care of patients long term. We essentially ask caregivers to be like nurses and right, like how much, you know, caregiving takes place along the way. It's
day to day. For the first 100 days, you have to have, I had 2 full-time caregivers taking care of me.
Oh, and you have a very supportive husband. Let's give a shout out to him and tell us what it was like for him.
I can't even imagine all that he had to process and go through and take care of me physically, and as well as my daughter. They were a team, and I don't think one of them could have done it alone.
What advice do you give to family members? I mean, give us some nuggets of info.
Hang in there.
Yeah, just where to start. I mean, you know.
I mean, a lot of caregivers are sacrificing so much and they're not taking care of themselves. So finding ways, I always tell caregivers, I know it sounds impossible, and everybody's saying, oh, take time for yourself, when they can't. They're like, I have to be with my loved one 24/7. So finding small ways to get a break.
Without feeling guilty.
Without feeling
taking care of
guilty.
themselves,
Exactly.
You know, for a brief moment away from taking care of their loved one.
Right. Because if they're broken and they're not taking care of themselves, they can't take care of the patient. It's the whole put your mask on first on the airplane before you put the mask on your child or your loved one.
It's a good way of looking at it. Pam, what surprised you the most? What did you learn? Is there anything you could share with us about just the emotional, mental journey that where you are today, and what do you walk away with?
I walk away with how fortunate that I am that I was at KU that has these programs in place, because it was bigger than I thought it would be. The emotional impact has been really hard, and I feel guilty with my family. So, you know, she has helped me realize that they love me. That's why they're still here and they're helping. And even though it isn't over, she's really made a difference. She's teaching me life goes on. Life goes on.
What words of wisdom can you share to someone who maybe has gone through this, is in the middle of a diagnosis, maybe awaiting a diagnosis? I mean, just how important is it to find that reinvention of yourself, and what do you want them to know?
I want them to know that you don't have to do it alone. That's what the team here is for. And don't be afraid of the names. Like when you first mentioned palliative clinic, I'm like, no.
And explain why. Dr. Muenks, explain what the palliative clinic is for folks listening.
Yeah, so the palliative,
and what it means.
Yeah, the palliative care clinic, to palliate means to symptom manage. So a lot of the history of palliative care, I think, combines palliative care with hospice. So people hear palliative and they think hospice, they think I'm dying.
That's a scary word,
And I often try to help patients understand a little bit more about what they do, because sometimes I'll say, technically what I do is palliative care. It's symptom management. It's quality of life management.
Yeah.
There are quality of life doctors.
It's the hope of treating cancer like a chronic disease eventually, where you go on and you live a very, very long life.
Yes.
And you do it well. I want to get to our takeaways today. Dr. Muenks, I'm going to start with you. What do you want folks to know?
I think I just want folks to know that it's a marathon, a marathon that nobody signs up for. You're just on it, and it's long and it's hard, and there's hurdles, and some people's mile 1 is really hard, and some people's mile 15 is really hard. Sometimes it's 20, but there's stops along the way, right? There's water stations, there's a first aid station, there's coaches of all sorts along the way to help patients cross the finish line, so to speak, and then keep running afterwards.
Yeah, that's a great illustration. Thank you for explaining that. Pam, as always, just thank you for letting me come to your beautiful home and sit down and meet your dogs and your husband and spend time with you, and just thank you for sharing your story. What do you want really the big takeaway to be from your story?
I guess get help, because it's there, and it's so hard, because I take every day now as I'm grateful for every day, every moment. And you often hear people say that and then it trails off. I don't. I really am. Every day is a gift. Every single person in my life is a gift. So just know that there's hope. There's hope. And
Treat each day as a gift. Perfect message to start our week on this Monday, and we just appreciate you as well.
Thank you.
Okay, thank you both.
Thank
All right,
you.
thanks to our guests. Thanks to all of our viewers for being with us. We will see you back here on Wednesday. Coming up Wednesday on Open Mics with Dr. Stites.
Cheryl Craig didn't have a pulse in her foot and amputation was possible, but a better treatment let her keep her foot. I'm Alexis Del Cid. On the next Open Mics with Dr. Stites, the promise of artificial arteries sewn into the body, Wednesday at 8 a.m.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.